diagnosis.
My dear vascular colleague, let me introduce today one of the most eminent vascular consultant, not just in UK, but worldwide, and who has left quite an impact in my generation. He is Professor Malcolm Simms. He is Professor of Vascular Surgery in Birmingham University. And we have a saying in UK that if there is any operating theater, there is always shoes for Malcolm to go in. He used to do a lot of vascular operation and procedure, both in United Kingdom and abroad, out of his human initiative, just to help developing countries to develop their vascular services. He is unique in teaching us how to perform a vascular surgery. It left quite an impact on me and my dear brother, God bless him, Dr. Isam Osman, while we were his registrar in 1996. We spent 1 year with Professor Malcolm. It left quite an impact in my whole career, in my whole life. And I would like to grab this opportunity that he's not busy as before. And hopefully I will I will grab this opportunity and let him talk about his career, how he started his medical career, who have taught Malcolm vascular surgery, and why he selected this topic. Please, Malcolm.
Thank you very much. I was born in Liverpool in 1946, brought up in the same area where the Beatles developed, and went to grammar school in Liverpool, and then we moved to Cheshire. And I was always impressed by the family doctor who came to visit, which is why I decided to pursue a career in medicine, and therefore took the necessary A-level examinations and applied for medical school. In those days in England, the medical schools in London were open for application before the national regional medical schools. So I applied to London schools, and I was accepted at St George's Hospital in London. I think mostly because the dean of the medical school was a runner, and he wanted to get runners for his running team, and I was a good runner. So I got into St George's Hospital and did pre-clinical at King's College on the Strand, and then went to St George's Hospital, which was then at Hyde Park Corner, as well as at Tooting in South London. Hyde Park Corner is now the Lanesborough Hotel, a very expensive place to stay. It's a lovely 17th century building, like a Georgian classical building. And whilst on the firm at St George's Hospital, one of the teachers on the surgical firm was James Gillespie, who was one of the first British vascular surgeons who'd studied in Houston with DeBakey and Cooley. So he'd come back from America, and he was bringing vascular surgery to St George's. He was a rather interesting Scotsman. I can remember the dramas of his cases. On one occasion, the nurses were called because there was blood coming from under the toilet door in the ward toilet, and a patient had blown his groin anastomosis. And this was great drama. On another occasion, I was watching him in an operating theatre, having a bit of difficulty with an aortic anastomosis, a proximal aortic anastomosis for an aneurysm. And he said to his assistant, "I don't like this anastomosis. I'm not sure it's going to be very good, but we'll give it a try." And he took the clamp off and said, "Oh yes," he said, "there she blows." Yes. So this was all very fascinating and so on. But I still didn't know what to do in medicine. And I went to Winchester as a house officer and did a house surgery job. And there the consultant kindly allowed his house officer to undertake minor operations lists or varicose vein injections alternate weeks. 1 week he'd inject varicose veins, the next week he'd do lipomas and lumps and bumps and so on, small minor surgery. moles and so on. And I found I was able to do this with a bit of advice from the nursing sister, who said, "This is what you do, tie a knot here and cut there." And I thought, I can do this. And so I thought, well, perhaps I should think about surgery. And in order to make my mind up, I decided to do an obstetric job in 1970. So I went to St George's in Tooting and became an obstetric senior house officer. And there, the registrar, who was very kind, allowed me to sew up wounds, and then got me doing cesarean sections and contributing to hysterectomies and so on. And I just found that it seemed to come naturally. So I thought, okay, I'll go for surgery. And then I went through the usual surgical training, went to Epsom, did an accident and emergency job, which gave me some time to study, and I got primary FRCS in 1971. And then I worked for Bob Taylor, who was at St George's later on, and he was a vascular surgeon. He'd just been appointed at Epsom, where I was working, and Bob Taylor inspired me to take up vascular surgery. It was never easy to pursue a career in surgery in those days, and London, I had 2 children, so London was unaffordable. Couldn't afford a house, couldn't afford to live there. So we moved up to Stoke-on-Trent, and Stoke-on-Trent gave me a lot of good general surgical experience. And again, I found that I could do the operations. It was okay. And started to write papers in Stoke-on-Trent, and then came to Birmingham, which was the nearest academic centre to Stoke-on-Trent, and was appointed as a paediatric registrar. I got my FRCS in Stoke-on-Trent, and in paediatric surgery, got the feel for doing finer work and more delicate work, and on the children, and that seemed to suit me quite well. Wrote some more papers there, and then got appointed as a transplant registrar at Queen Elizabeth Hospital in Birmingham, where I came under the tuition of Tony Barnes, who was one of the first British transplant surgeons. And he was another good teacher, very excellent surgeon, very talented and charismatic, highly intelligent, driven man. And he was very good at delegating work. So you were very soon doing fistulas and transplants and all that sort of stuff. And so, again, a good chance to develop technical skills and appreciation of how to handle arteries and so on. And with Barnes, I was able to get a research grant. So when I finished the transplant job, I took up transplant research, and I was doing research into immunosuppression in rat kidney transplants. So I had to teach myself how to do rat kidney transplants. And it wasn't that difficult. I went down to Oxford, where they were running a program under Peter Morris, and he had a technician, a young lady who was possibly a dental nurse or something, and she was an expert at doing rat kidney transplants. And so I went down to watch her doing rat kidney transplants and came back able to do it. Got all the techniques together.
Your hand skills is fascinated. Me and Isam always fascinated. You can do suturing right-handed and left-handed. And when you're doing anastomosis, we're just amazed. You must have noticed this in your career early on. You're gifted in your hand.
When I became working for the professorial vascular department at the Queen Elizabeth, I was working for Professor Frank Ashton and Professor Jess Slaney, both very talented surgeons and good teachers. And I was very pleased when I was working for Ashton, and he said, do this anastomosis. And after the end of that, he said, you should take this up. And that was very encouraging. So they gave me great encouragement. Yes.
Okay.
And certainly with the rat kidney transplants, I got large numbers done and so on, and got some useful data about cyclosporin and its effectiveness in rat kidney transplants. And so after 2 years of that, I went back into clinical vascular surgery and we trained under the professorial vascular unit at the Queen Elizabeth Hospital with Ashton and Slaney. And went on from there. And Slaney was then appointed as president of the Royal College of Surgeons.
Yes.
So I was his lecturer, and he was away in London a lot of the time, and I was given quite a lot of freedom to develop techniques.
Yes.
And of course, having these microvascular skills with the rats, I thought I should apply this to patients. And there were, in the late 60s, early 70s, we were seeing a lot of publications from America on distal bypass and bypass to tibial arteries.
Yes.
And I'd noticed that I did a little study once when we dissected amputated legs. And we went down to the morgue and dissected the amputated legs and did some studies and found that there were patent arteries down in the calf which would have received a bypass graft. And I thought, well, how do we get blood down to these patent arteries in the calves? And obviously, vein is a very tapering structure. When you get down to the calf, it can be quite small. And sticking that small vein, by reversing the vein, sticking it on the femoral artery in the groin, the hemodynamics are not particularly good. And so again, I read and heard about in situ technique and using the long saphenous vein non-reversed by destroying the valves. So I studied this work, and so the in situ bypass story and the femorotibial bypass story, and started doing these cases. At first I was doing them, and again I was doing these unsupervised really, because Professor Slaney was away in London and I was given carte blanche to do what I wanted. And so if we had a case of critical ischemia with an unsuitable popliteal artery, then I'd go down and get onto the tibial arteries and using the in situ vein technique. And the results appeared to be quite good.
Yes.
Initially, when the in situ technique was developed, the word in situ was taken literally, and you left the vein in its bed and you tied off the tributaries as well as you could by whatever techniques you prefer to use, and various techniques of finding the tributaries. And certainly there were complications. Then you'd have unligated tributaries, and you'd find patients with little pulsating veins on the thigh emanating from the graft that you constructed, and occasionally little areas of venous congestion. And of course, by leaving the vein in its bed, the incisions you made for the access to the vein to tie off the branches and remove the valves, they were the vein was left close to the surface. So occasionally you had a situation where a wound would break down, leaving an exposed pulsating vein graft. And you can imagine that wasn't a very good thing. Sometimes you had blowouts occurring. Yeah. So all these complications led me to think, well, I think we should dissect the whole vein out and run it back in a deep tunnel. So that was eventually, after 5 years of struggling and mistakes and so on, yeah, I decided to use the long saphenous vein as a non-reverse graft, valve destroyed, running through deep tunnels down to and after that, we didn't have any complications of fistulas and blowouts and so on, and wound breakdown, etc.
Yeah.
So that was the technique I used.
Yeah.
Most of my career.
Yeah, I was told you were giving master course in the Royal College for fin distal bypass. You were in charge of.
Yes.
Is it still running this course?
That particular one, isn't it? It was organised by John Wolfe. You remember John Wolfe from St Mary's Hospital? John Wolfe, yes. He ran this course, and I was on that for some time. Yes, he invited various vascular surgeons to help him run the course, and I was one of those. And that was we enjoyed that course. Yeah. And then we had another course at Selly Oak Hospital where I was working later on.
And what is your advice? Yeah, what is your advice to young vascular surgeons struggling with doing a good anastomosis in a deep field? And you must have learned a lot of lessons to make you such an expert in this field.
Yes. Micro instruments, magnification. When I started doing tibial bypass, we were using operating microscopes, very cumbersome. Yeah. And then I realized that by using magnifying spectacles, loops. But
Yeah.
in my case, it was 3.5 times magnification. So
Yes.
with magnification like that, you can work comfortably in a narrow field with micro instruments and with the right sort of retraction and so on.
Yeah.
And you need flexible wrists and that sort of thing. In my case, my hands weren't terribly big, so it suited me with smaller hands. But plenty of surgeons with big hands do very good distal anastomosis work, so it's not a requirement.
Yeah, and the way you hold the needle holder, you told me once not to use a finger grip, but to use a palmed grip in order to have, because when you are suturing, it's as if you are moving the needle like 360 degree, and you're very cool as well.
Yes. Pronation and supination in the wrist is very important. I mean, obviously we're working with curved needles, and the needle you have to work along the curve of the needle in order to place the sutures perfectly. So a rotational action is absolutely essential, and then you'll get good penetration of the tissues without trauma. So yes, it's very much a supinating action. If you're right-handed, it's a supinating action in order to get that right, to get the needle through the tissues quickly.
Yeah. And to use your right.
I wanted to.
Yeah. To use your right hand.
So the
techniques,
this
is something. Yeah.
Yes, mostly I'm right-handed, but yes, tying knots with the left hand is important, and yes, a certain amount of bimanual dexterity is useful, but it's not essential. Yeah.
Okay.
I think the main thing is good lighting, good retraction, and patience, etc.
Yeah. Okay.
I wanted to make a few comments about.
Yes, please.
About the approach to limb ischemia.
Yes.
And the whole concept of limb ischemia, if that's all right.
Yes, please.
I always taught the students to say that there were three types of ischemia: functional, critical, and acute. And that functional was where you weren't able to, the body wasn't able to cope with the demands of exercise, muscular exercise, that there was sufficient blood flow to keep the tissues happy at rest, but the flow could not increase to meet the demands of exercise. And that was functional ischemia, meaning claudication. And with claudication, there's usually one anatomical level of occlusion in the arterial tree, a single level of occlusion. Critical ischemia is where the blood supply is not sufficient to fully meet the requirements of metabolism and thermoregulation. And so critical ischemia means that there is a risk of erosion of the skin, failure to repair injury, and so on. And that's where you start to get ulceration and rest pain and so on. And generally speaking, with critical ischemia, there's more than one level of anatomical level of occlusion, two levels. For example, common femoral, superficial femoral, or iliac and femoral, etc., or superficial femoral and popliteal trifurcation, two levels. So, and in order to correct these deficiencies, you have to bypass, because the aim is to get normal pulsatile flow into an area of low resistance outflow beyond the block. So for a graft to succeed, you need to have a low resistance outflow bed below the level of the block. So for most patients with critical ischemia, you need to bypass two levels, which is where the use of the long saphenous vein and with the non-reverse technique comes in, because you need a long graft for that sort of thing. So, for example, if you have a patient with critical ischemia and there's a femoral pulse that you can palpate, then you can judge from that they're going to have occlusion at the superficial femoral level and at the popliteal trifurcation. So most patients with critical ischemia and a good femoral pulse have some degree of two-level occlusion, and you need to get good flow down to the tibial vessels.
Yes.
Not invariably the case, but often the case. In fact, when I first started working as a consultant at City Oak Hospital, the vascular radiology at that time was very rudimentary. We didn't get good angiograms. We hadn't got CT imaging, etc. Modern. Well, no, Martin Dudley hadn't arrived then. When Martin Dudley arrived, things became much more advanced. But before he came, a lot of the imaging was translumbar aortograms, which was a very ancient technique, quite dangerous. Yes. I've seen patients die from translumbar aortograms. Yeah. With dissection of the. You can imagine. Yes. So I tended to avoid preoperative angiography, and I worked at techniques of evaluating critical ischemia with portable Doppler techniques and clinical evaluation. Which proved to be. We did a paper in the BMJ in the 90s about non-invasive assessment, and it did work very well. And later on, when the angiography got more refined, you still found that your clinical assessment would not disagree with the angiogram, a good angiogram. And so the clinical assessment was right. So but what I was doing really was looking at, is there critical ischemia? Is there a low ankle pressure? Is there a Berger sign with a hyperemic foot independency, pallor in elevation? All of that. And if you would bypass to the tibial artery with the best signal, and which seemed to be perfusing the foot. And we worked out just simple clinical ways of seeing which tibial vessel fed the pedal arch best.
You told me this test, it was very nice, a pedal arch, PT dominant or AT dominant arch. This was very good tool, still used until today.
Too.
Yeah,
just simple digital compression. And you have to bear in mind that in quite advanced ischemia, it can be quite difficult to detect a signal in the pedal arch, and you may need the patient to have the foot dependent for some time to be able to detect a pedal arch signal. But with patience and time and a quiet room, you can pick it up. So these very simple techniques, which can be applied in the clinic, will give you a very good strategic approach to the need for bypass and so on. So I think it's so important. The diabetic patients, of course, present difficulty because diabetic patients have multi-level disease, often significant infrapopliteal disease, and the confounding factor is the presence of neuropathic ulceration and when it's not so much the ischemia as the neuropathy that's causing the damage. And often with the diabetic patients, there will be vasomotor neuropathy, so that they do have a red-looking foot independency, just like the Berger sign, because they haven't got normal vascular, microvascular tone. But in those patients, if you elevate the leg, they won't blanch in the same way that the critical leg will blanch. So if the foot is red in dependency and it doesn't go pale at elevation, then they probably have the diabetic.
That's all right. You can answer the phone, no problem. Okay.
My secretary was doing the answering.
Okay.
Yes. So obviously, with the diabetic patients, the pain is a different quality of pain. They may have neuropathic pain, but it's not the same as ischemic pain. It isn't necessarily worse at night and so on as the diabetic, as the ischemic patients are, etc. So I think with clinical appraisal, you can try to distinguish the diabetic ischemic foot and the neuropathic foot from the genuine critical ischemic foot and so on. So you need to be careful there because, of course, if you try to bypass in the patients with diabetic neuropathic disease, you often find that the distal vessels are not adequate to take a graft, and you can end up disappointed and so on.
That's true.
But modern angiography, etc., will eliminate some of these difficulties. But it's still important to make sure that your clinical intuition and clinical appraisal matches the angiographic appraisal. Otherwise, you can get distracted and make wrong decisions.
Yeah.
So it's always good to check.
Absolutely. Absolutely.
Does it make sense?
Yeah. No, absolutely right. Yes. I've also learned
And
it
now
from
my
you.
other
Yeah. I've learned from you the weapon of local anesthesia. You taught me how to do varicose vein under local anesthesia, stripping
yes.
and multiple avulsion, how you can do below knee amputation and above knee amputation under local. I remember when you had difficulty with anesthetists and some of your list being cancelled, that you developed this technique that you will have your operating list without anesthetist. Can you tell us, because a
Yes.
lot of generation will benefit from that?
Yes. Well, clearly local anesthesia has great benefits in terms of timing and risk for patients with cardiovascular disease and so on. Essentially, most patients would prefer to be asleep for their operation because it's yes. So I consider that the epidural in the hands of an expert is the optimal technique for distal bypass for stable patients and low risk, etc. But there are some patients in whom epidural technique is not allowed because of anticoagulation or possibly other occasional issues, spinal issues and so on. And local anesthesia is a good option. Certainly, a distal bypass under local anesthesia is much less traumatic to a patient than an amputation, both in the short term and the long term. So the technique of local anesthesia for distal bypass is quite simple. It's quite easy to infiltrate the groin, to get access to the common femoral artery, just simple regional injection of usually prilocaine. I find 0.5% prilocaine is the best agent. It's quick acting, low toxicity.
Yeah.
And with about 20 or 30 mils, 0.5% prilocaine, you can usually cover the whole common femoral area and the profunda and so on, and get access to the long saphenous vein, etc.
Yeah.
And then for the next level, a little more, another 10 to 15 mils of prilocaine will give access to the above knee popliteal artery. A little more to get deep into the popliteal fossa, and then it's quite easy when you've got a bit of experience to go behind the superficial femoral artery and locate the sciatic nerve. The sciatic nerve runs just behind the superficial femoral or popliteal and below it. And once you get access to the sciatic nerve, you can just put a direct injection of prilocaine into the sciatic nerve, just 10 mils. Yeah. And that will numb the sciatic nerve at that level, in which case the whole leg from there on down is available. Yes. So really you can achieve a good block in the leg with, no more than 60 mils of 0.5% prilocaine, which is well within the toxic availability. And with that, you can do a distal bypass. And it's a very simple, safe technique. Yes, I think it's always advisable to have a good anaesthetist on hand to give the patient a little bit of oxygenation and reassurance and so on, and monitoring, etc. But the pain relief should be absolutely fine. Yeah. So I think unfitness for anesthesia is not a bar to limb salvage surgery. That's the important message to get across.
That's very good. Very good. And you also can do femdistal bypass using arm veins, which very few vascular surgeons are using this technique. So, and you are an expert in using the arm vein. So, how do you advise young surgeons?
Yes, obviously the long saphenous vein is available in the leg, but it's got to be good vein. You can't accept long saphenous vein that's phlebitic or hypoplastic. It has to be at least 3 millimeters diameter to be usable, and it needs to have a nice elastic, expansile wall. If there is phlebitis in the wall of the vein, it's rigid, the endothelium is irregular, and it won't sustain flow. Arm vein is usually very good, and obviously it's a little more trouble to remove it, but everyone's got decent arm vein. Usually the cephalic is usable, but you can use all configurations, the ulnar vein, the cephalic vein, the basilic vein. So you need to study the anatomy of the arm veins, and I've never caused any long-term morbidity in the arm from harvesting arm vein. No instances of thrombosis or swelling of the arm.
Yeah.
It is possible to cause some minor cutaneous nerve injury, but with care you can avoid that. So the wounds heal pretty well.
Yeah.
So the morbidity of arm vein harvest is minimal. It just takes a little time, and you've got to use local anesthesia in the awake patient, which can be. It means that you need another 50 mils of prilocaine. Ideally, if you have a patient who's not fit for general anesthetic, then the ideal situation will be to use epidural for the lower limb and local infiltration for the upper limb. Yeah. And that will achieve a good compromise.
You take external carotid from the neck as well when you want a little bit of vein, or this is a little bit rare?
Very unusual. Very unusual. The external jugular vein is rather thin-walled. Any vein above the heart tends to be quite thin-walled, and they're not that robust. Arm veins, interestingly, of course, are more robust near the wrist, because that's where the pressure is higher.
Yeah.
The more proximal you go, the more fragile the wall is. But in fact, all the veins in the arm, I've never had problems with aneurysmal degeneration of arm veins in the leg.
Yeah.
It seems they seem to be quite robust. Yeah. I think they arterialize in situ, and they don't become aneurysmal as a general rule.
Yeah.
I think the one thing to remember about arm vein in the leg is that the tapering will vary anatomically from patient to patient, and often you will want to use the vein in the non-reversed or the reverse situation.
Yeah.
So you have to be aware of the valves and take into account exactly what to do with the valves.